Hi, my name is Michelle Root, and today I'm going to be talking to you about systemic lupus erythematosus, or SLE for short. So a short overview about SLE, it's a chronic multi-system inflammatory disease of connective tissue. It's it's the most common, complex, and serious of the autoimmune disorders. It's characterized by the production of a large variety of autoantibodies against your DNA, your histones, your ribonucleoproteins, and other nuclear material in your body. It can involve the kidneys, your skin, joints, serous membranes, central nervous system, hematological system. It's a disease of remissions and exacerbations, and it can be anywhere from mild, aggressive, and even life-threatening in presentation. What puts people at risk for the diagnosis? Age is the main big factor. 85% of cases are women between their 20s and 30s. Only 15% of cases present after the age of 55, and there are about a 20% of patients younger than 16 that have been diagnosed with lupus. Gender is a big risk factor. Females are 10 to 15 times more likely to have lupus than males. So that's a pretty big difference. Race, people of African descent are 4 times more likely to develop SLE than Caucasians, and then research has also shown that in Asians and Hispanics, they're disproportionately affected compared to Caucasians. And then, of course, genetics. There's been a study done on monozygotic twins showing that a gene called the HLA-DR class II MHC gene that's present in affective individuals, and it occurs most often in monozygotic twins. 3 key questions that are essential in the workup for this diagnosis. So you'd want to know, are you taking any of the following medications, or have you ever? Procainamide, hydralazine, anti-tuber necrosis factor agents, or minocycline, because there are an estimated of 15,000 to 30,000 cases of what they call drug-induced lupus per year. It's actually equally as common in males and females, and then it is also more common in older adults and Caucasians, which is kind of the opposite of lupus, or like systemic lupus. So that's a really important question to ask, because they may in fact be presenting with lupus symptoms but may have drug-induced lupus. Are you aware of any family history of systemic lupus? And are you a twin? Because of the gene linkage we discussed earlier, it does have a genetic predisposition. Have you ever experienced any of the following issues? And these are your primary issues for SLE complaints, basically. So fever, fatigue, lymphadenopathy, weight loss, photosensitive, skin lesions like the butterfly rash, painless oral or nasal ulcers, hair loss, Raynaud's phenomenon, joint pain, swelling, dyspnea, chest pain, seizures or psychosis, recurrent miscarriages, and any 4 of these, it's generally like an 11 common symptoms. Any of the 4 would push you towards doing, more diagnostic testing to see, if in fact that patient does meet more criteria for the diagnosis. 3 top physical examination components that must be examined. You need to look at their skin. They look for the butterfly rash, alopecia, lymphadenopathy, and Raynaud's phenomenon. Examine their musculoskeletal system, joint pain or swollen joints. Neurologically, look for impaired cognitive thought process, peripheral paresthesias, and diminished deep tendon reflexes. Cardiac, they may have a systolic murmur. They may also have some JVD, which could implicate right-sided heart failure or pulmonary hypertension. And then for GI, look for painless oral and nasal ulcers, right upper quadrant tenderness, or right lower quadrant tenderness. Overview of the most common treatments for this diagnosis. The primary goal is control. Dietary modifications should be based on presenting symptoms, history, that sort of thing. Make sure they look for a support group that will help them kind of cope with their diagnosis. For the treatment of fatigue, we would want to do corticosteroids, DHA, hydroxychloroquine. For musculoskeletal pain, we would look at NSAIDs, which would be your COX-1 inhibitors, and then your COX-2 would be like Celebrex, Vioxx, Bextra. For cutaneous infections, Plaquenil is the go-to. For any type of multiple organ involvement, glucocorticoids may be used, and they could be used individually or in combination with an immunosuppressant. A newer medicine, a B-cell lymphocyte stimulator, is Benlysta. It's been shown to reduce disease flare rates and improve symptoms in patients who are positive for the autoantibody for lupus. NSAIDs are anti-malarial controllers. If they're not working, you may need to move to immunosuppressants, Cellcept, Amuran, Cytoxan, and then there's a new drug called Rituxan. It's actually not used, it's not FDA proven to be used for systemic lupus, but it has been used, it is being explored as a treatment option. 3 priority teaching components. Rest is essential during exacerbations. Increase fluids and use the correct dosing of NSAIDs. Patients should understand the need for professional intervention when their temperature escalates beyond 101.5 degrees because it could be an opportunistic infection in moving in on their immunocompromised body. Immunizations should not be avoided except if they're immunocompromised. Don't get the live attenuated vaccines. Avoid sulfonamides and tetracyclines because they may exacerbate photosensitivity. And then women should avoid pregnancy until they are at least at remission for 6 months because of the high miscarriage rates due to thromboembolism. And that is a brief overview of SLE, and I went over 5 minutes, and I'm really sorry.